Evening. So today we will be discussing joint action terminology. Whenever you hear the word terminology, I know they kind of glaze over because you're thinking regular anatomy, right? Where you have to know all the terms, it's just a part of it. So as we dive into the content today, try not to glaze over because it's very applicable and you're going to use it for the rest of your career and life, I promise you. All of the things that we learned today, they are a foundation, and you'll see these words pop up quite a bit. There's also a few concepts that we're going to apply from the content that we're absorbing today. So it'll be a good one. It'll be an interesting one. Now, over the next few weeks, you guys are going to be taking your exam. We'll be still meeting for class next week. But just heads up, because I'll be moving, so my background will change and it'll be kind of hectic, but we will still have class and I just won't have as much paint on my hands and forearms. Moved in. So just bear with me as that goes. But you guys will have an exam next week. We'll kind of touch on some of the content after we go through this section of material. Like I say, joint actions, they're just what's going on within the joint. You guys will probably recognize some of the terms that we use. Some of them you might be very well versed in and you use them every day in your job, in your profession. Some of them, they might be new. And then we'll also kind of talk about the actions and the associated instruments that kind of help them as well. So give one more minute for everybody to kind of hop on here. I think I've almost gone through everybody's journal article submissions. They were awesome, by the way. I loved going through them all just because I learned definitely from you guys and kind of your interests and some of your background. So I found that really interesting. But then also some of the content that you sent me as far as the articles, the research papers, I loved it because there's a diverse group, but you guys were targeting and kind of on the same wavelength of, trying to understand the material and make it apply, not just, okay, great, they gave me a bunch of numbers. Did they actually apply it to the real world? And so I love that with that. If you check it out, go look at my feedback, because sometimes what I did was I asked you questions. You don't have to answer those questions unless you want to. Shoot me an email. I don't mind. Let's chat. But the point of me just kind of giving you a few answers or a few questions, was just to get you thinking, especially for your next one. Because it's always good to, as we're reading those articles, we can kind of get lost in the words and be like, great, another research article. But if we can start to apply it right off or think critically about that, it can, again, help us integrate it later on and we'll actually remember it versus just discard it for later. Okay. All right, so we got a couple more people. Any questions before we get going, you guys? Like I say, we'll go over some of the exam content after. Can everybody hear me okay? Alrighty, well, let's just dive in. I'm gonna pull up our PowerPoint. So today, like I said, we're going to be breaking down joints and joint action terminology. Now we've kind of talked about the different sections, appendicular, axial, skeleton, things of that nature, but now it's kind of cool to break it down to what's actually happening within the joints. You don't have to have a lot of anatomy background for you to start to understand this. And actually it'll help whenever you get into anatomy because you'll understand why the structures are the way that they are. Well, actually I already started to kind of, I want to say cross-pollinate, but use some of the stuff that we've been talking about in here in my human anatomy class that I'm teaching, and it's really helping them grasp and absorb some of the materials. So I'm going to do that to you guys as well, but it won't be as term heavy for you guys. All right, so let's just dive right in, shall we? So joint specifics, a joint in and of itself is a juncture of two or more bones, basically where one meets the other. Function is so that we can have movement, stability, and limited shock absorption. So Think about it this way. If we were like stick figures that we draw, I don't have any artistic ability whatsoever. So my drawings are stick figures and they're not very good. I paint on walls better than I draw stick figures versus real caricatures. And think about it, if we were fused, you know, at our elbows and knees and we had to walk like a stick figure where we just had the two lines shooting off, that'd be quite boring and we would have limited movement. Think about the trunk, the torso, that straight line that we draw through a little stick figure. If we can segment our spine or hinge at the waist, kind of limited, right? But it also gives some stability because a lot of joints, barring the hips and the shoulders, there's limited range of motion in that, you know, it doesn't go all the different directions. And then it does have some shock absorption, as well as, you know, just some. There's other things that give us some more shock absorption, but it does give it some. Okay. Got everybody in, hopefully. All right, so let's talk about the types of joint movements. So we have two different types, physiological versus accessory. Physiological is movements that result from an active muscle contraction, excuse me. So that means whenever, say we bend at the elbow, so we flex at the elbow, that is a drawing in, that's a contraction of our bicep. Accessory movements happen, they're the result from that physiological movement. So because our bicep contracts, what actually happens within that joint capsule itself? And they're necessary for our joints to actually maintain that congruency that it keeps. And it cannot be actively performed in isolation. You have to have, you know, those physiological movements in order to get these accessory. And the accessory movements, it's kind of interesting because if we did not have these, we would not be able to have physiological movements in general. But also, whenever these accessory movements aren't happening correctly or efficiently, we can actually see that with things like the knee joint if it's not hinging correctly, or getting that little roll glide, which we'll go into it in a second. If it's not getting that, then sometimes that's where we can open up ourselves to pain, injury, and just dysfunction within the joint. So let's talk about two that you guys probably know. Flexion. Flexion is a decrease of a joint angle. So you know how I was saying like a bicep curl, right? So we bend at the elbow, kind of like this gentleman's doing here, and we flex our hand towards our shoulder, using that bicep. Then you have extension where you're straightening out, increasing that joint angle. Hyperextension is actually where you go past that like zero line and then you go past into a hyperextension. I can do it with my elbows. I can't really show you here on screen. Some of you might be able to do it with your elbows, your knees. There's different conditions that might, you know, predispose you to that. It kind of makes for cool party tricks, but also opens you up for a lot of injury and other concerns. But it's something good to note. All right, so let's talk about two more that sometimes get confused, but they're pretty basic. So we have abduction versus adduction. Now, I say it that way because AB versus AD, that kind of helps us separate that out. But abduction is the movement of a joint or a body segment away. And then adduction, so adduction, adding to the body, is bringing the joint or body segment towards the midline. So AB is away, AD is towards you, it's adding. That helps you remember it, great. But I always try to distinguish it. Some people, they don't say that AB or AD, but it just kind of helps, especially if we're teaching virtually and we're not in person here. Any questions on that? All right, since I'm hearing crickets, we'll move on. So let's talk about internal or medial rotation and external lateral rotation. So these happen within the joints, commonly seen in the hip and shoulder here. Internal rotation is the joint or the body segment toward the midline. So that's why it's like medial rotation, right, towards the midline. Most of what I use is usually internal rotation within a joint. Lateral or external rotation would be away from the midline, which kind of makes sense if we go back to what medial and lateral means, right? For the most part, at least in my field, what I do, internal and external rotation is kind of what we refer to. So it's, if you think about it this way, whenever we have what you see here, you guys, with the femur and or the tibia, the leg kind of rotating in and out, internal, external rotation. So think about the knee, where is it going? Internal rotation versus external rotation. And I might just send you guys some YouTube videos that I really like that kind of cover this. It's like animated, so that really, really helps you see things. I'm a visual person sometimes, so I'll send you those as well. Let's talk about elevation versus depression. So elevation, superior movement. So think about lifting your shoulders, shrugging your shoulders. You elevate them. And then depression, depressing the shoulder blade, inferior movement of that joint or body segment. So think about it this way: whenever your move's elevated, you're rising up, and whenever you're in a depressed mood, you're kind of down, right? So those kind of, it's definitely seen in the shoulder girdle. Kind of easy to think. So this one, feel free to do it with your hand. Nobody else can see you, they can just see the screen. Supination versus pronation. So in the wrist, the rotation of the forearm from the thumb position medially to the thumb position laterally. So that means like this. Hopefully you guys can see that. Should be able to see on my paint too. So we're going like this. I always think of, I'm holding a cup of soup, or I'm holding a cup of coffee, because I like coffee. Okay? And then pronation, the rotation of the forearm from the thumb position laterally to being positioned medially. So I'm thinking I'm pouring out my cup of coffee, which is just tragic, but pronation, pouring out that cup of coffee. So supination, receiving that soup; pronation, pouring out that cup. Hopefully that helps you. All right, so let's talk about the foot. So this is seen in the foot: plantar flexion versus dorsiflexion. Toe up versus toe down, okay? So plantar flexion, so the plantar is like the sole of the foot, remember? Plantar flexion, the movement of the foot where the foot is placed in a toe down position. So think about it like this, where it's like stepping on a gas pedal. Whereas dorsiflexion, that's where you actually take your toe towards your shin. So usually whenever I'm cueing patients or clients, whatever I'm doing, teaching a class, teaching a workshop, or seeing a patient, excuse me, that's what I'll tell them. I'll be like, okay, press your foot down, point your toe, step on a gas pedal. They kind of get that visual. Or dorsiflex, so pull your toes towards your face, or pull your toes towards your shin, and they usually get the picture. Now this is happening at the ankle joint itself, okay? So inversion versus eversion. Inversion refers to the ankle movement in which the calcaneus, so that's like that heel bone, rotates to where the sole of the foot positions toward the midline. So inversion, foot in, is what I think. That helps you, great. If it doesn't, just discard. Eversion refers to the ankle movement where that heel, the calcaneus, rotates to where the sole of the foot positions away from the midline. So think about this. If this is my foot, I'm going like this, inversion or eversion. A lot of our injuries, which we can see here, especially in basketball and so many others, soccer comes to mind, we have a lot of eversion, right, where we roll our ankles a lot. Inversion might happen with cutting as well. Not as common as eversion sprains, but you still see them. All right, supination versus pronation. Again, we're still looking at the foot here. There's a lot of stuff that goes on in the feet. They're kind of cool. So you can see the pictures here. Hopefully that helps you out. Supination and pronation, before we even get into this, both are good things. You can have too much of a good thing, just like we had with our lumbar spine, T-spine, C-spine. But they both happen naturally, because we've always kind of heard it associated with not good, right? We hear that, yeah, my foot supinates too much or caves in or whatever, but it does naturally happen during the gait cycle. So just because you do supinate doesn't mean that it's a bad thing. Do you pronate? Then great, we got them both. Now there is too much of a good thing, so keep that in mind. But as we go through here, it's not always a bad thing. Happens naturally. So in the foot, the combined movements of talar dorsiflexion and abduction, and calcaneal inversion. Whew, that's a lot. So let's look at supination. Usually I have somebody come up and demonstrate. You have to get on the table and everything, but we're going to try to make this work without doing that. So look at our supination guy right here. So we're right over here. So at talar dorsiflexion, does everybody remember what dorsiflexion means, right? Pull the toes towards the face. So it's kind of a little bit of dorsiflexion. Abduction, what does abduction mean? Anybody? We just learned it, so here's your chance to apply it.
It means
Pulling away.
What does abduction mean?
Away.
Don't everybody talk at once.
Away. Flying.
Take away.
Away.
Who has it? Crickets. Okay, you guys get off at this one, but I want answers for the next one. Abduction means that we're taking away from the midline, correct? So we're coming away. And calcaneal inversion, so that remember is the sole of the foot towards the midline. So that's how you get eversion. So you get that section right here going out and the section right here going in. Oh, sorry, I couldn't hear you. So y'all were saying it, but I can hear it. Fantastic. Okay.
Correct. Can you hear us now?
Yes, I can hear you now. Sorry, guys. Thanks for participating. Sorry for telling you guys too. Thanks for answering, and thanks for letting me know. So now that you guys can hear me and I can hear you, let's break down pronation, shall we? In the foot, there's combined movements of plantar flexion, adduction, and eversion. So now, you know, we're breaking it down into several different locations, what's going on. So what is plantar flexion?
Straightening the foot out.
Plantar flexion is what?
Toe away.
Nope. Plantar flexion is down. So you're pointing your toe. Now, adduction, what is that? Whenever you do what to the joint?
You're adding to it.
Yes, ma'am. Thank you. And then eversion, what's happening with that ankle and foot?
The bottom is rotating outwards.
Yes, exactly. So you get this segment right here. Looks pretty funky, right? I think of my son whenever he's walking around. I'm like, oh my God, there's so much pronation. But it's just because he's little and he doesn't have, you know, all the bad habits that we have, and he can handle that load. But what happens is it's almost like a caving in. Again, pronation, if you're thinking about pouring out that cup of soup. But the sole of the foot is actually going outwards, and that it's almost like the medial ankle bone, that medial malleolus is tipping inwards. So again, supination, now that I can hear you guys and I can hear you and you can hear me, that ankle's rolling out and kind of that the sole of the foot is rolling inward. And then we got pronation where that ankle's rolling inward and the sole of the foot is rolling outward. Does that make sense to everyone? I'll think that is yes. Okay. So now we're kind of broken down the foot. Let's go to our wrist. So this one kind of makes sense if you think about it. Radial deviation versus ulnar deviation. So the ulna, is on, if you're standing in anatomical position, it's under. So if that helps you think about it, great. Radial deviation is whenever the wrist carpi deviates toward the radius. So that means it's actually going towards the outside. So if we're standing here in anatomical position, I'm going to raise up my arm, we do radial deviation. Whereas if we're doing ulnar deviation, we're going towards the ulna. Does that make sense to everybody? That one's pretty common sense, right? We're deviating towards what it's labeled as. All right, so now let's talk about the shoulders. So protraction versus retraction. Protraction, the movement of a joint anteriorly. So think about rolling, like Hunchback of Notre Dame, right? Where they kind of cave in, right? Protraction, I always think of like you're moving forward, so you're forward thinking, versus retraction, which is where you move the joint in posteriorly, excuse me. So it's kind of like you're squeezing your shoulder blades back and down. So retraction, you're retracting your vote, you're against it. So protraction versus retraction, those ones get easily flipped sometimes because we think protraction and some of us want to think posteriorly, but always pro means anterior, retraction means posterior. Now into the digits, opposition versus reposition. The movement of the thumb and the fifth towards each other. So you see it right there in the picture. Versus reposition, which is where you just go back to the high five position, okay? So opposition, reposition. Now this one's fun for me. Anterior tilt versus posterior tilt. So we're looking at the pelvis here. Anterior tilt, the anterior rotation of the pelvis about the left and right axis. So you'll see right there on A, right, chia. Kind of like you're pouring out a cup of soup out the front side of you. You see that hyperlordosis right here kind of coming in, right? Versus posterior tilt, I think of like you gotta go poop or you're squeezing a penny between your butt cheeks and you kind of tuck your tailbone under like a scared dog. That's where you tuck that pelvis under. And then neutral pelvis, as seen here in B, is where we're kind of between the two pelvis level and neutral. Okay, these two, it's kind of not like one versus the other. It's more solo gig. Lateral flexion, so the flexion of a group of joints away from the midline, specifically directed at the spine. So that's something good to note, kind of underline. Specifically directed at the spine. So think about taking your ear to one shoulder versus the other, that's a lateral flexion. Then forward flexion is where basically you take your face down towards your feet. So think about hinging at the waist forward fold. This happens again at the shoulder joint as well as you move your arm up and down. Last few. Horizontal abduction extension is the abduction of a joint or body segment in the horizontal plane. Horizontal adduction or flexion is the adduction of a joint or body segment in the horizontal plane. Kind of makes sense, right? It's basically abduction, adduction, just with horizontal in front of it. Guess what it means? It means that you're moving in the horizontal plane, okay? Circumduction versus rotation. And sometimes people get these confused, right? Because you think circle the same way, right? Circumduction, rotation, you're thinking you're making a circle, but they are two separate things. So circumduction is basically a combination of movements to achieve that circular pattern. So basically it's a mosh pit of all the things, right? So you're making that circle, that gentleman's right there at his side with his fingertips from the shoulder joint versus rotation. One surface spinning on another or coordinating spinning movements of many segmental levels. So the gentleman right here is doing a rotation through the spine. It's commonly seen in yoga and many other modalities. But you can do that rotation on your spine, and what's occurring, it's not just one vertebra that is rotating. It's all multiple different vertebrae all up and down the spine that is rotating, each having its own little chorus, own little segmental rotation. Now the fun part is whenever you put your detective hat on, and if you're seeing that she's not rotating evenly on one side versus the other, what's going on? Do we not have a vertebra rotating properly, or are there muscle imbalances that we need to take a look at? Now, you will see these videos on the PowerPoint. The PowerPoint should be up for you guys. Double check me, email me if I'm wrong. But you will see these 3 different YouTube links. Take them, look at them. Kind of helps you understand things a little bit better. So before we go into roll, spin, glide, all those fun accessory movements, do we have any questions? Usually these terms are pretty straightforward. So, all right. We shall push on.
Oh, actually, I forgot to ask. Is chapter 5 going to be on the exam?
I don't believe so. I'm going to pull it up here in a second and I can confirm that, but I don't believe so. I try not to do that because that's kind of mean, but great question. All right, so roll. Don't overthink it. The joint motion in which several linear points on one joint surface come into contact with one point on the corresponding joint surface in linear fashion. So what in the world does that mean? Think about it this way. You have a bunch of different, I should just grab a pen, shouldn't I? Yeah, let me grab the pen. Maybe. We are moving, so everything's in boxes right now. But since I have paint all over me, I might as well have pen, right? So say, if this guy will write, I'm going to use my middle finger here, and I'm going to be, all these different points are going to be corresponding with one point on the top of my middle knuckle on the other side. So I have, does everybody see that lines? We usually do this with bones, but we're improvising here. So with my middle knuckle right here versus in lines over here. So several linear points on one joint surface come into common with one point on the other surface. So here's what we have. Right? Kind of get this rolling motion. Not much happens down here, but up here we get that roll. Make sense? Let's move on. Let's see if it does. Versus spin, which is where one point on one joint surface and one point on another joint surface move about an axis. So think about two fingers going together and rotating. We have spin. It's not two, just one. So it kind of get confusing if we were trying to like rotate with 3 points of contact, right? Versus say that one in the middle is doing the rotating and the other ones are along for the ride. So one. So we have many to one and one to one. Then glide. A joint motion in which one joint surface translates on the other, or both joint surfaces translate against each other in opposite directions. So think of it this way. You know how we kind of had that roll thing going on? Now we just have this. So either this one's moving or both of them are moving in opposite directions. That's where you get that gliding action. Again, I've incorporated that video for you guys to watch so that it's not just the points on my hands and my fingers. It's actually animation to where it looks all nice and neat and pretty, but that will also help you understand that if you're having trouble distinguishing between the three. Any questions on that one? Okay. I always think of like glide especially. I think about whenever I do an anterior ACL test where say I think that somebody's torn their ACL. And we'll be showing you this later on whenever we talk about the knee, but I'm kind of grabbing that lower leg and I'm kind of translating it towards me. There's a glide happening and I'll try to take that tibia towards me. Hopefully it doesn't move that much, but sometimes it does, and that means that we have something torn and something's missing. But it's a glide, so we're gliding on that surface. Again, roll. We have multiple points coming into contact with one point. Spin, we have 1 point on one point on the other, spinning around, coming in contact with one another. And then glide, we have that kind of shimming back and forth, where either one is doing the movement or both are moving in opposite directions. And then traction. So we've probably had this done to us before. If you have it, feels great. Maybe where you have traction placed in your cervical spine, like this lady does right here with a traction machine. Or maybe it is your lumbar traction where somebody pulls on your legs and kind of gives you that space in your lumbar or in your pelvis. Or like this gentleman's doing right here where he's pulling down on the arm, giving a little bit of traction just to see if we have any separation there. That's actually a special test. Not very fancy one, but effective. So traction, basically you're increasing that joint space. Just giving it a little tug or a little bit of pressure pull away from the joint to give it that space. Sometimes on purpose, sometimes not. Compression, so basically you're doing the opposite. You're pushing it in, you're compressing, you're decreasing that joint space. So traction, we're pulling it, we're adding space, creating space. Whereas compression, we're pushing those two joints together to see basically if we can create pain or cause any concerns, symptoms when we compress. How does that, everything make sense so far? How are we feeling? I know that I can hear you guys now, so since I'm not hearing anything, I'm guessing that we're good. All right, so the concave, convex, thumbs up. Thank you. That helps. Told you guys, crickets scare me. I'm always like, are they still there? Have they all fallen asleep? What's going on? So, convex versus concave rule. Think of it kind of like a sphere to start, and then we'll break it down a little bit more here in a second. And I also have a video for this because it's helpful to see it in animation. Trust me, it helped me a lot just to see that, and I just replayed the video 1,000 times over. So convex versus concave. Convex, the curved outward like the outside of a sphere. So think about like how the sphere is, it kind of curves in like this, right? So it's kind of like a C shape. So it's the cup. Versus concave, curve inward like the inside of a sphere. Curved inward like the inside of a sphere. That makes sense to everybody? We'll give some examples here in a second. All right. So for this one, we have something that's kind of moving in opposition of each other. So I'll just read out the pure definitions, then I'll kind of do the movements with my hands. I'll have a little chat, see how we understand it. We'll move on from there, okay? So let's just read the definition purely. When the concave articulating surface is fixed, gliding will occur in the opposite direction. When the convex articulating surfaces is fixed, gliding will occur in the same direction. What in the world does that mean? Okay, so you guys will see these pictures again, hint, hint. Not on this exam, but the next, I believe. Say we have a stable convex. The concave, making that C, so cave, C, is moving. Because I think I said that backwards last time. So I always think of like concave, making a C. So this is stable, this is moving. Whenever the articulating surface is fixed, oh my God, I'm saying this wrong. Sorry, guys.
It looks like it's convex with the C. Right?
Yeah, I'm so sorry. I just got it mixed up in my mind. I'm so sorry. Thank you for that. Let's try this again. I think I do this every year because I have this stupid thing flipped right here that always messes with my mind. Okay, let's try this again, y'all. Okay, so whenever the convex is moving, let's just try this all over again. Okay, so whenever the concave articular surface is fixed and the concave and the convex is moving, I'm gonna get it right here in a second. So we have the C is stable, convex is moving. We get a opposite direction. So this is fixed, it's not moving at all. This is moving. We have a opposite direction of glide. Why? Because think of your shoulder. You have the shoulder socket right here, and here's my arm going up and down. If it was moving in the same direction, so this was actually doing the motion, and I was trying to say lift up my arm, so this was going to go in the same way. Do we see how we would get impingement at the top? Versus this one, if we're going down, we get impingement at the bottom. Sorry, I'm kidding. If it would give me my stuff, I would be able to. I'm sorry. You got this, Professor. Thanks, Desmond. Woo, it feels like a Monday. So again, I switched them, which apologies for this because I just switched it whenever I was reading it. So apologies. Let's go through it again. So when the concave articulating surface is fixed, so it's not moving, gliding will occur in an opposite direction. Why? Because with that gliding, we're able to not have pinching occur in the joint. Look at it right here. So as I adduct my arm in, the top of my humerus right here is actually gliding upwards. If it were to glide in the same direction as my humerus, we'd have pinching, right? Which you actually get in dysfunctional shoulders, especially with baseball. Mark, I'm looking at you. You kind of get this where instead of there's some articulation in the opposite direction, it actually almost gets stuck and kind of pinches in. So in a healthy joint, you want to have that concave, convex. Whenever the convex is moving, we're going to have an opposite glide. So as we're adducting and the humerus is moving in, the articulating surface at the joint is actually moving in opposite direction. Makes sense now that I royally messed it up and confused you even more, because this is a hard concept and I just made it 10 times harder for you guys. Let's go over convex and then we'll chat about it again. So when the convex is fixed and the concave is moving, and see what I did was why I read it wrong was because I had this flip-flopped. Sorry. So whenever we have a stable convex and the concave is moving, the movement and glide will occur in the same direction. Think about it if it were to move in opposite direction, how confusing and pinchy that would be. So think about I'm going this way, but this decided to move this way. Instead of moving with me, it was going this way. It would be like that versus moving along the articulating surface at the same time. Okay. How do we feel? Now that I really confused you and then brought you back and then confused you again probably. How are we feeling? See, Chris is like, eh.
When you say direction,
Yes.
sorry, when you say direction, do you mean like the direction, or I guess the angle that the bone is leaning towards?
Yes and no. So think of it this way. If I am adducting, so I'm adding my humerus or my arm to my body, what's going on in my bone is going to be opposite of what's going on in my joint. So as I add my arm in my shoulder socket, that joint is actually gliding oppositionally so that there's no pinch. Whereas, I'm trying to think, just had brain fart. Whereas like that convex, if it's stable, it's not moving at all. This guy is moving, so our concave is moving around. Whenever we have this movement, everything's going in the same direction. Do you see how my arm goes out? It abducts as this is stable. And so what's happening right here at my hand is going in the same direction as my arm. Does that make sense? Again, I incorporate a video and we'll actually review this concept next time. And I promise not to mess it up and confuse you guys even more. Apologies. Probably just going to go through and actually flip-flop these two guys right here just so that I never mess up again. Because for some reason, switching up the order got me. Hey, how are we feeling? Rate me from like 1 to 10. 1, I have no idea what just happened. 10, nailed it. Put it in the chat. If I see any 1s, I'm so sorry. I have failed you. Okay, 7, 6, 7.5, 9. Ooh, I'll take it. Yeah, Amanda, you don't count. You've had this like a bazillion different times, but I'll take it. Okay, Misty, love it, 10. You probably had that with Breckenridge too. And you probably didn't jack it up. So obviously I need to work on my PowerPoint positioning of my pictures. Okay, I'll take it. So 7, 8s, 9s, we'll take it. What I'll do is I've sent you those videos, watch them, don't get confused from those, and then we will go over it again next time. I'll bring up the same PowerPoint. You'll probably see the words or pictures flipped because I'll be like, gosh darn it, I'm not making that mistake again. So hopefully that makes sense though. Like I say, if you think about it within the joint, especially within your shoulder, you would want it to glide in opposite directions. Otherwise you get that shoulder impingement that a lot of baseball players feel, that a lot of professionals feel. If you think about the hips, same thing there. If you're going to go kick a soccer ball and you weren't getting that oppositional movement, you would get a pinch in the front of your hip every single time. And it gets gosh darn annoying, and it does because it happens a lot in soccer players. Okay? All right. Miss James, did you mean to send me a file? Okay, that's kind of creepy. I'm just gonna move on. All right, so what that means, when the glenohumeral joint abducts, remember AB, so we're going away. Gliding occurs in an inferior direction, right? Because it's going in the opposite direction. I'm not going to confuse you and go into the fingers until next time. I want you guys to go watch that video. Okay? Sorry for messing up the most important slide right there. All right, now I'm just kidding. So all motions discussed occur in one of the three cardinal planes: flexion, extension, sagittal coronal plane, abduction, adduction, frontal plane, internal, external rotation, transverse plane. So do you see how those kind of came back? I haven't really used those words in a while. But if you start to put on your critical thinking hats, you're thinking about, okay, flexion, extension, especially if you're thinking bicep curl, sagittal, right? Makes sense. Abduction, adduction, frontal plane, makes sense. Internal, external rotation, transverse plane, makes sense, right? Okay. Couple other things to note. For motions that occur in an oblique plane, do we remember what that is? That's basically where we mushed them all together. It's like, whoa, right? We actually use degrees of motion because otherwise we'd be completely lost. So forward flexion of the glenohumeral joint, what does that mean I'm doing? Doing that? Yeah, I see everybody doing the zombie hands here. So forward flexion. And then with 35 degrees of horizontal abduction. Horizontal. Going along the horizon, and I hit a wall. Okay, so we're taking it away from the midline. Abducting. But you see how I had to use degrees there to kind of show you how far out I went? Because that's not in like a plane. It's in between planes. So we have to use those degrees as kind of directors. The iliofemoral joint, 15 degrees of flexion. So you're kind of hiking, bringing your knee up. And, so flexion right there. And then 15 degrees of external rotation. So that's external rotation, taking that knee outwards at the hip socket. Again, videos will follow. Videos are attached here. Watch them, that will really help you out. All right, so how do we feel about this? Because the most important concept right here that kind of throws everyone is the concave convex, just because some things move in opposition versus some things move in the same direction. The reason for that is so that we can clear the joint. If we didn't, then we would have that pinching. Because we haven't discussed this yet, and some of you have not taken anatomy, but you know, if you have a joint capsule that is that concave, say the shoulder or the hip, you have that labrum surrounding the outside. So say if there is not that oppositional movement, you would have something, so say I'm going to do it wrong, this is dysfunction, going in the same direction, you're going to clip the edge right here as well as that hip labrum. So think about hips. I think about hips because I've had hip surgery. I've actually had some of this go on. So I know how annoying it is. I'm a former soccer player, ran a lot. So I was like the prime candidate for this. Whenever you have that translation and you have that pinching where you knock into this, it starts to create inflammation. It starts to create a response where you have pain. And every time that you do that flexion or adduction, you have that pain because your joint is not centrating correctly within the joint. It needs to be right here. But whenever it's all going in the same direction, it gets out of centration. Whereas if you have the oppositional movement, my lovely little hip socket, it stays centrated while that femur moves in and out. Does everybody see that? If not, we're not in the center. We're clipping my thumb here. So we're not staying in the center if we're moving the same direction. Whereas if we have that convex and then the concave's moving, we're going the same direction because we have this nice little C shape. I always think about it kind of like, it's going to be kind of silly, but whenever you're, say, you have a cone and then you have your ice cream sitting on top, it's going to spill over the side unless it's going with you, right? I think of my son whenever he's like trying to lick the ice cream and then he does it poorly and then loses all the ice cream off because he didn't go with it. Same rules apply here. Don't lose your ice cream. Make sure that you go with the movement. Okay. All right. Heads a scratching. I see sort of look of confidence. Some of you kind of look confused. But how are we doing right now? Any questions before we review? Hopefully I recovered from my oopsies. No, y'all are awesome. So again, watch those videos. That'll really, really help you out. And I'm going to pull up the exam exactly, because why not look at the exact exam? That way we know exactly what we're dealing with. So this will be online, will be on Blackboard. Don't ask me how much I hate putting exams on Blackboard, because I might have lost 50 questions whenever my computer crashed one time and I about cried. So labor of love, y'all. So whenever we're talking about this exam, we're going to have a few matching at the very beginning. And I'm looking at my paper version, and it's going to be a little bit tweaked going into the formal Blackboard version, so just a heads up. But I want you guys to know the different directions. So remember stuff like anterior versus posterior, definitions like kinesiology, prone, volar, all those things are good to know. Multiple choice, so you'll have 15 of those-ish, roughly, matching. Then we'll roll into some multiple choice. Take your time with these. I don't think I even said, I think I gave you guys all 3 hours for this. So you guys will have plenty of time, take your time. So think about things like the axes that we talked about. So kind of like movement that occurs in the horizontal plane will have a what axis, et cetera, et cetera. Know those kind of matching. Same with like sagittal plane, what axis will it occur in? Thinking about the properties of connective tissue, good to know. The ability of a tissue to lengthen and return, what is that? Like I'm literally reading from the exam, so just heads up. I'm thinking again, we're bringing back in some of those major things like condyles, spines, foramen, fossas. So those kind of features of a bone, you need to know those. And trust me, that'll help you. We just went through the skeletal system in my human anatomy course, and they're all sweating it because we're about to do the practical, and they're gonna have to know all the multiple ones. And so learning a few of them now will help you so much. Dense regular connective tissue, maybe know some, what those are. What do they make up? What connects muscle to bone? Know about your cervical vertebra. Know a little bit about the makeup of the bone. So do you guys remember that YouTube video that I sent you where it had the like dynamic, where it kind of broke down the components of the bone, the osteon, the canals? Know those different components. Maybe have a picture of that. That'll help you. Know the types of ossifications, processes, okay? There's only 2. Know what makes up a bone. So like the different components of a long bone. Good to know. Just kind of giving you some flashes here and there. So numbers 15 through 34-ish, give or take a few, is going to be the matching. Why I say give or take a few is because some of them in the online version of the exam kind of had to shift a little bit just to the makeup of the exam. Then we switch into critical thinking questions. So the first one, I actually have you put in order what's happening whenever you have a bone ossification process. I'm not going to tell you which one just because there's only 2 of them, so you got this. But you need to know the different orders, the steps. Okay. Spinal curvatures, good to know. Various spinal curvatures. Then I think I have to go back and see. Should I have a couple extra credit questions on there? Like signs of inflammation, what are they? I might have another one on there, but it's escaping me, but it's extra credit. You got this. And that's it. So there's not very many questions to this exam. Not like 150 questions, okay? There's like 30 something, okay? As you go into this one really didn't have any of the clinical application stuff in it, just because, I mean, we just went over that last time, and that was more for an FYI sort of discussion. So it opens tonight. You have until Tuesday. Now, I am telling you this from personal experience as well as students before you and in my human anatomy. Please do not wait until Monday or Tuesday. Just don't do it. I do not want to get an email later about you freaking out because it's not working. Because I feel for you, but there's some things that I can fix, some things that I can't, okay? I want you to get started on it. Try to do it this weekend, knock it out. Trying to think, by Monday, heads up, we're going to be moving. So my connection to my computer will be limited. So I will try to make myself available to you over the weekend, especially be checking it in the morning and evenings whenever I get home from moving and supervising floor being put in. So I will have that time sectioned off for you guys to make sure that I check in on my inbox. I'll also check in on my phone. So as much as I can, I'll make sure that I get back to you guys as ASAP. But Monday's probably gonna be a little crazy. So that's another reason for you not to put it off. Okay. Any questions? How are we looking? It's a pretty straightforward exam. I try not to do any trick questions. I hate trick questions, hated them in school, don't like them as a professor. Okay. Any
So all of the questions essentially could be answered throughout the PowerPoints, right?
So I purposely make all my exams from the PowerPoints. There's no other resource that I've given you, nor any book. That's why I don't make you guys get a book, right? I give you everything on those PowerPoints. Everything that you need is on there. Kind of that old saying where like just everything that you need is in the book for the exam. Well, everything that you need for the exam is in my PowerPoints. Okay. Anything from the spine hip diagram? Great question. No. So you will not have to fill out a hip diagram. You will not have to fill out a spine diagram. I kind of think that that's mean right now, but I can bet you money that guess who's going to be filling those guys out? My human anatomy class. Especially say if we went online, I'd be like, here you go guys, here's a picture of a vertebra, fill it out. What are all these different points? And then you see their eyes get really, really wide. But for here, we're more applied, okay? Anything else? Great questions. All right. If you have any questions, stay on here. Otherwise, have a great night. Email me with any questions or concerns. Like I said, I'll be pulling it up on my phone more as well as on my computer, especially this week for y'all. Other than that, have a fantastic week. We will see you next Tuesday where we get rocking and rolling on some new content. I think somebody's joining me on the sidelines this weekend. So shoot me an email And I can give you any directions that you need. Starts at 7. If you want the next home game, if you want to be on the sidelines with me, shoot me an email because that one's still open, because I think that we only have 1 or 2 more home games. So unless you want to travel with me to Kansas, Oklahoma, which nobody wants to do that, just come to home game. All right, you guys, have a great evening, and we will chat later. Bye.
Thank you.
Thank you. Have a good one.